أنا
as a physician Dear colleagues, good evening. First of all, I wish you and your families safety during these difficult times. Despite the exceptional situation we are facing, we remain committed as physicians to continuing our medical education in order to better serve our community and our patients. The Hippocrate platform and team are honored to host this webinar organized by the Lebanese Society of Dermatology. It's also our great pleasure to welcome our dear colleague, Professor Selin Aractingi, who is joining us from Paris to share his expertise in a lecture on gestational dermatosis. I would like also to express my sincere thanks to Dr. Rami Abadi, President of the Lebanese Society of Dermatology, for his dedication to education despite the many challenges we are facing. For logistical reasons, Dr. Abadi will be addressing us through a pre-recorded video.
I hope you and your families are safe during these challenging times. I also hope that the situation will improve very soon. It is my great pleasure to introduce our distinguished speaker for today's webinar, Dr. Selin Aractingi, the head of the dermatology department at Institut Cochin. Today, he will be presenting on gestational dermatosis, clinical features, and evidence-based management. We are truly honored to have him with us and look forward to his valuable insights and expertise. The head of the Dermatology Institute Cochin. Today, he will be presenting on gestational dermatosis, clinical features, and evidence-based.
Dr. Rami Abadi, thank you once again for your commitment and for your determination to organize this webinar despite all the challenges we are facing. Now it's my great pleasure to invite Professor Selin Aractingi, who is joining us from Paris, to give his lecture. During and after the presentation, please feel free to share your thoughts and ask your questions in the chat space titled comments and located under the streaming screen on your laptop or on your mobile phone through the Hippocrate application. Professor Aractingi will be happy to address your questions at the end of his lecture. Professor, the floor is yours.
Good evening. Good evening to all of you, dear colleagues. First of all, thank you, Professor Youssef Bakhash, for inviting me and proposing me to discuss this subject. Thank you, Dr. Rami Abadi, for hosting us under the auspices of the Lebanese Society of Dermatology. And I would like to say exactly what said my colleague and friend, Dr. Bakhash, is that I'm far from Beirut, I'm in Paris, but all our thoughts, all our prayers, all our wishes are with Lebanon in this really difficult time where part of my family is, and I really share with you what you feel. We are living this from far, but with the same acuity, and we wish you safety, good health, and hopefully peace. And although it may seem maybe not mandatory to discuss medicine, science, as my friend Dr. Bakhash said, maybe it's good also for continuing to do something else than singing to our daily situation. So we decided yesterday that we will do this small session. It's going to be a small session, and I'm going to try to share with you this presentation concerning pregnancy dermatosis. Are you able to see my screen, Youssef?
Yes. Yes, you can share it. You can put it bigger. Okay. It's
okay.
Perfect.
Is this
yes,
okay?
It is perfect.
Okay, so good evening to all of you. So maybe some of them have already heard me talking about this. And what I try to do, because so these are my disclosures, and there is none in relation with this presentation. And as an introduction, I want to tell you that, of course, I will not be able to address everything, because you see that you have many chapters when you are a dermatologist and you are dealing now with pregnant women, where you are going to have many potential reason for asking an advice or consultation, a clinic to dermatologists, with all the chapter presence here. And you see that some of them, a lot, are physiological changes. I will not have time to address this, but just keep in your mind that nearly 100% of women who are pregnant are 100% in all series are going to have physiological changes, and you have now to reassure them, because pregnant women have become anxious. They have become anxious because they are afraid of something that can indicate any disorder, and you have to try to reassure them. So what I've tried to say is, or what I'm trying to focus is, are on skin situation that should alert because of the risks for the fetuses. And you see here that there are mainly 4 chapters, and I will focus on the 2 first one. And I will just say one word of the 2 last ones. But of course, if you want to ask me questions on the other during the discussion, I would be happy to try to discuss this with you. So feel free to ask your question whether you would want to. So just what is called in the literature the pregnancy-associated dermatoses are 4 chapters. And you see here, you have these 4 chapters. The first one are benign inflammatory dermatoses, called either atopic eczema of pregnancy, AEP, which is considered to be the most frequent one, either polymorphic eruption of pregnancy. This is an entity that was known under other names previously, like POP, PUPP, or prurigo of pregnancy, etc. But now it's grouped under this name, this denomination. And you have to know that these 2 disorders have no consequences for the fetus. So I will skip them from the presentation. And you have 2 other pregnancy dermatoses, intrahepatic cholestasis of pregnancy, or pemphigoid gestationis. And these 2 may overexpose the fetus to a risk. And I'm going to begin with pemphigoid gestationis. So what is the story of pemphigoid gestationis? So this is interesting because it's a rare autoimmune disorder of the pregnancy, previously called herpes gestationis. If you go to older chapters, it will be called herpes gestationis. And the mechanism is supposed to be this one. When the placenta is developing little by little, where the trophoblast cells are going to not express the paternal HLA antigens, except HLA-G, and HLA-G is more an immune suppressor HLA rather than the other HLA class 1 and class 2. But in the situation where there is pemphigoid gestationis, there is an abnormality, and instead of having only HLA-G, I have something that is bothering me here that I want to take off from here. Okay, and there is also something that I try to take off from my screen. Okay, so there is an abnormal expression on the trophoblast of HLA class 1 antigen, or sometimes class 2. So these antigens are, as you know, HLA is 2 alleles, one of the maternal origin and one of a paternal origin. And if you have an abnormal HLA class 1 expression, you are going to have paternal expression of this allele, and this is going to trigger production of antibodies against HLA, and some of these are going to react with collagen 17. Collagen 17 is a protein that is present in the dermal epidermal junction. That is the autoantigen called also BP180 kilodalton. And this one is the autoantigen of bullous pemphigoid. And this is why you are going to have this triggering of autoantibodies that is going to target both the placenta of the skin. And what is going to happen is that you are going to have all effectively a skin autoimmune disorder, but also a risk for the placenta and therefore a risk for the fetuses. And therefore, what are you going to see is papule, vesicule, itching lesion. Just you have to know that 90% of pemphigoid gestationists are not featured by blisters, but mainly by eczematous or papular lesions. This occurs mainly during the third trimester of the pregnancy. They are mainly appearing and being mainly on the abdomen of this woman, usually also concerning the umbilical area, but you can see them at distant lesions like the hands and the feet. And what you see here is not the skin, and this is the placenta. And what you see here is really similar to what you are going to see if you do electron microscopy or direct immunofluorescence on the skin, is that here you see C3 linear deposition in the trophoblastic, along the trophoblastic cells. And what you see here is that you have abnormalities in the hemidesmosomes that are less well expressed. And what you see here is that you have a separation within the placental cells and at the basement membrane of the placenta, like the skin. And this is a study done in Finland. And therefore, what is the risk for the fetuses is that you are going to have a risk of stillbirth. You have also delayed growth of the fetuses, one third, low birth weight. And all this, if you take a series of women who are followed with having a pemphigoid gestationis, you have much more preterm birth, small for gestational birth, and low birth weight than the controlled 34 versus 6, 34 versus 6, 31 versus 7. And you see here that therefore the children are going, the fetuses are going to be at risk. And you have even some case reports with fetal loss because of this delay in the growth of the children. And if you want to try to associate or to characterize in which situation you have the worst risk for the fetus, you have just to understand that it's mainly the the mother, where the pemphigoid gestationis are going to appear in the first trimester or in the second trimester, as compared with the pemphigoid developing in the third trimester, which are not at a significant increased risk of fetal growth retardation, and also the presence of blister. And remember that I told you that most of the pemphigoid gestationis did not display features. So just keep in your mind that you have risk for the babies, that you cannot skip, and you have to manage this with the obstetrician. And this increased risk is more important if the disorder begins early, first or second trimester, and if the disease is blistering. And therefore, you have all this risk that I've already discussed with you. And therefore, what you have to do is to be in contact with the obstetrician and ask them to follow up the pregnancy with ultrasound regular examination. And if there is any, I would say, advertisement that you have low birth rate or delay in the continuous growth of the baby, sometimes the obstetrician will take the decision to extract the baby before, depending, of course, of what is happening. And therefore, it's our duty of dermatologists to be in contact with the obstetrician who doesn't know well what are the risks, explain them in what type of risk you are, in order for them to do adapted follow-up for these pregnancies. The second pregnancy dermatosis is intrahepatic cholestasis of pregnancy. This situation, they know it very well. But sometimes the diagnosis will be done by we as dermatologists. What is the clinical situation? I will not take the same time that for the other diseases. So it's much, it's also, sorry, it's also a rare disorder. The country where it is the most highly present is Chile, and this is because of genetic predisposition. I will not take your time to explain you why. These women have isolated pruritus. Sometimes they may have secondary excoriated lesions, but it's a cinemateria pruritus, and therefore the best examination, the best biological examination is to do a blood test. Just keep in mind that for the pemphigus gestationis, you have to do either a direct immunofluorescence, either ELISA for anti-BP180, because the classical histology for pemphigoid is not enough. So here you don't need to do a biopsy, neither an ELISA, but you have to do the measure of the serum circulating bile acid, and when you have a high level, well, you know that you have this intrahepatic cholestasis of pregnancy. And what is happening is that the bile acids are going to accumulate, they're going to be transferred through the placenta, and they are going to accumulate in the brain of the baby, and therefore you have a risk for the brain baby, and this is managed by the obstetrician with their specialized pediatrician. And this, what I can show you here, is secondary lesions. There is no primary rash, but if the disorder is going longer, the women, after scratching too much, are going to have either linear excoriation crusts, and this should not let you have a delayed diagnosis, because you have really to, if you have any fear, you have really to do this serum bile evaluation. The third chapter are what we call TORCH, and TORCH means Toxoplasmus, other, rubella, cytomegaloviruses, and herpes viruses. But as I'm going to show you here, TORCH is a name of the 80s. It's the beginning of the 80s that Anglo-Americans have used this denomination, but now it have gone to other words and other causes. I put you nearly everything here. And again, after pregnancy dermatosis with pemphigoid, after pregnancy dermatosis with intrahepatic cholestasis of frequency, you have infections. And in these infections are frequently featured by a skin rash, a skin maculopapular exanthem, which are not specific. And the ladies or their doctors are going to ask your advice. You know, in my hospital here, in Cochin University Hospital, in the building just 20 meters from me, we have really a big obstetric departments, and there is not any week where we don't have such of these women, where the obstetrician are going to send them to us. And we had one woman just a few days before, when she has a HHV6 infection. I could have put your picture, but I'm going to show you other similar pictures. It was only macular papular exanthem. She had some erosion of her tongue, and it was an HHV6 infection at the 37-week of pregnancy. But it was not a torch, because the HHV6 have no risk for the feature. So I'm just going to show you a few examples of this. So usually this pathogen that I've shown you in the previous slide, I transmitted by the blood through a transplantal route by, of course, the umbilical cord vessel going to the blood circulation of the baby. And therefore, depending on the term of the pregnancy infection and of the type of the microorganism, you may have various malformative or embryologic consequence. And therefore, this, of course, you have a duty of doing all the tests to try to determine where there is a risk of infections with a fetal risk. And this is what I'm going to show you. The point that you have to keep in your mind is that all these infections that I've just shown you here, they have no pathognomonic semiological good reliable sign. Means that every time that you have a rash, a maculopapular rash, whether it's rubella-like, whether it's measles-like, whereas it's more scarlatiniform-like, well, there is nothing specific in your skin semiology, neither in your histopathology, and this has been shown by a lot of papers. So you are not rely on your experience to say, well, this is not measles, this is no rubella-like, etc. This is really false. You have to be like systematic in having your examination. So just a few infections, for instance, CMV infections, that is going to be, for instance, responsible for a lot of deafness. So you see that it's a more prevalent one that you are going to potentially be exposed to. Again, the mother can be exposed through different way, mainly to mucous membrane exposure. Then you have a risk of infecting the fetuses where you are at a primary infection, but also potentially a reactivation of the CMV. And this is what we call a mononuclease-like pictures. And you may have a lot of consequence for the children. And the diagnosis come by either PCR in the blood, either by detecting the IgM in the plasma. And there are treatments that should be discussed. I put you one of my patients here, and you see here you have this large erosions in the posterior pharynx, which you see here is this fibrinoid covered erosion. You have other here in the posterior pharynx here. And of course, you have to think about it. Another one that you know better than me is toxoplasmosis. Again, there is no specific features to this maculopapular exanthem with classically posterior enlarged lymph nodes that are oriented to you with these ones. Potential severe consequence for the features for the babies. And the diagnosis here, you don't have a PCR, but you have IgM against Toxoplasma gondii, and you do an agglutination test, and the treatment is macrolides, which are fully arrived. Parvovirus B19 is somebody that I met many times in pregnant women, also in adults. Sometimes you have something that can evoke the diagnosis for two is livedo-like rash on the upper or the lower extremities. And you may have also pain in the articulations. The diagnostic relies on IgM serologies, and the risk is fetal anemia. And this fetal anemia can be treated by in utero transfusion. And I show you here one of my female adult patients also with this parvovirus B19 infection. Of course, rubella is less severe, but sometimes misleading. Again, the diagnosis comes from the IgM detection here. Every time you have a maculopapular exanthem in adults, you have to think about the primo HIV infection. And the primo HIV infection may really display various types of rashes, either moderate, either severe, with or without enlarged lymph nodes, with or without enlarged liver or splenomegaly, spleen enlargement. And here, of course, as you know, the diagnosis relies on the kit, and the kit does not only detect the antibodies, but also most of the modern kit, also the antigen, if you are in the window where you have antigen positive, antibody negative, and this should be done really systematically in all these pregnant women. This is rare in Lebanon, but we still see them in France, but it's much more in adults, what is called MSM, mean male who have sex in males much more than in pregnant women. And COVID-19 is more severe in pregnant women, so you have to do the PCR. Usually when we have patients who have respiratory symptoms with or without a rash, we do what we call the multiplex infection. I just put you here something that is not in relation with the way to diagnosis, but just to show you here a meta-analysis of pregnant with an active COVID-19 infection and not pregnant women. And you see here that despite the fact that you have no increase in miscarriages, you have fatal deaths that were found significantly higher when pregnant women were COVID-19. So you have also the duty to think about the COVID-19. This list is the reverse list of the first one that I've shown you before. So you have, with your prescription list, to do serology for all this virus. Of course, if you are not in the Caribbean or in other islands, you will not have the Zika virus, but the Zika virus can give an encephalopathy in the brain of the babies who are infected. So it is in Brazil or in the Caribbean or in the Maurice and other islands. Well, I skip this for Lebanon, but the other one I will keep them. This one, we do it systematically here. And you have to also finish with rubella and toxoplasmosis, except if women has previously known IgG. Varicella is outside of this topic because, of course, it's not a maculopapular rash, but of course it's vesicles and blister and obligated lesions. I finish with 2 slides, and this is a very rare disease that was previously called impetigo herpetiformis. When I was a resident, it was called impetigo herpetiformis, but it's a rare but important psoriasis, pustular psoriasis of pregnancy. There is risk for the mother. There is also risk for the babies. The treatment relies mainly on oral steroids, and you have consequence for the mother and for the babies that are features here. The diagnosis come from clinical features with biopsies, and you have to do a regular follow-up of the features because you may have this risk of prematurity and sometimes also, as I show you for pemphigoid gestationis, a risk of fetal death. This I will, of course, not detail them because you have a list of autoimmune disorders that are going to flare during pregnancy. The most frequent one is lupus, because lupus is, first of all, the most frequent autoimmune disorders that we see as dermatologists, and the most frequent one that can flare during pregnancies. And I've listed you here the fact that lupus is going to flare in the mother during the 3rd trimester and sometimes post-delivery. And the lupus is going to also be potentially responsible for risk for the babies that I've shown you here. And of course, if you see a rash like this one here, or an heliotropic rash, a butterfly rash on the face, of course, you have to discuss this with the obstetrician who are going to follow up the baby, increase the dose of, or introduce a treatment with steroid. And with this, I will arrive nearly on time at the end of this presentation. And just here, 2 points. I told you already that within the course of the 2 pregnancy dermatosis, means pemphigoid gestationis and intrahepatic cholestasis of pregnancy, you have to do a follow-up with the obstetrician. And the same will be for impetigo herpetiformis, called pustular psoriasis, that is, without any doubt, an indication for oral corticoids. And when you are facing a maculopapular exanthem, that can be COVID-19, rubella, toxoplasmosis, CMV, EBV, parvovirus B19, what you have to do is to be systematic within your blood test, with your blood PCR, with your blood serologies, really to try to detect all the torch renovated list to be sure that you are not facing a disease that is going to have a risk, and therefore to be in contact with the obstetrician to potentially discuss with him of this. And with this slide, I finish this presentation, and I'm going to look whether there is any potential question to discuss with. And I'm going to the Zoom presentation. Okay, so I have a few questions. Sorry, I'm going to stop the share of the screen. Dr. Bakhash, Youssef?
So, thank you, Salim, for this beautiful presentation. We have received a few questions, so they are already on your WhatsApp space. So you can read them, and I am checking on the platform if there are another questions coming from the audience.
Well, there is four questions that I'm just seeing because I was not looking to the. But is it okay like this, Youssef, if I put the light?
Yes, perfect.
Okay. Yeah, I will try to answer the one that you have sent me, Youssef.
Okay.
I think there are interesting one. So first question was that I'm going to read to the audience.
Please.
What's the role of skin biopsy and immunofluorescence in confirming the diagnosis of gestational dermatosis? So I'm going to try to answer you very, very clearly, and this is a good question. If you have at whatever is the trimester of the pregnancy, if you have skin itching lesions that are primarily pruritic, not secondary to the itching of the pruritus, means you have eczema lesions, urticarial lesions, prurigo lesions. All of this presentation can be either pemphigoid or polymorphic eruption of pregnancy or atopic eczema of pregnancy. But the only way to distinguish between atopic eczema, polymorphic eruption of pregnancy, or pemphigoid gestationis, the only way is either a biopsy or a blood test to detect anti-BP 180 kilodalton by ELISA. If you don't have it in Lebanon, you have to do immunofluorescence. So when you have skin dermatosis during pregnancy, except if it's only skin lesions that are secondary to itching, you have to do a biopsy or to do a blood test to detect anti-BP 180 kilodalton. So just be very large. Here in my departments, when we see the female very frequently, whenever we have any eruptive dermatosis during pregnancy, we do a biopsy and we do an IFD to be sure that we are not facing a non-blistering pemphigoid, because again, 90% of pemphigoid are non-blistering disorder. They are eczematiform lesions or prurigo-like lesions or even dyshidrosis-like lesions, so do not hesitate to do biopsies. This is the first question. The second question is interesting question also. What is the risk of recurrence in subsequent pregnancies for the main gestational dermatosis? So I'm going to answer you also very, very clearly. The risk is mainly for pemphigoid gestationis. When you have pemphigoid gestationis, you have risk for the fetuses, and then you have two other risks that are recurrence of the pemphigoid when women are given oral estroprogestative contraception or a new pregnancy, except if the father has changed because of stories of the paternal HA. So you have a risk of 10 to 20% of recurrence in pemphigoid gestationis when you have oral contraception with estroprogestative or a new pregnancy. So you have to follow them up. But with polymorphic eruption of pregnancy, the risk is close to zero. And for atopic eczema of pregnancy, the risk is not very clearly defined, but remains low. So your main risk is for pemphigoid gestationis of recurrence. So there is a third question that I'm discovering, and I read it on the WhatsApp. In severe cases, when do you recommend systemic corticoids, and how do you balance maternal benefit and fetal safety? So I believe this question concerns severe case of pemphigoid because it's not clear in the question. But I'm going to say that it's severe case of pemphigoid. So pemphigoid gestationis, in the older time, the treatment were oral 1 milligram per kilogram of prednisone orally. Then the second period in the literature and in our imaging was no more oral corticoids, but only high potency topical corticoids with 30 grams of clobetasol on the whole body. This was the second period in literature. We are still in this situation where mainly we give high potency topical corticoids. But in my view, high potency mainly clobetasol, clobetasol 30 gram, is responsible for severe atrophy of the skin. So there is 2 points I want to tell you. You can easily give oral corticoids to 0.5 and not 1 milligram per kilogram of prednisone if you have pregnant women with disseminated or severe pemphigoid gestationis, especially if they are resistant to topical corticoids. And the second point I can tell you, and this fits with the first question that is in WhatsApp. The first question is, are biological therapies or newer immunomodulators considered in refractory case? So this fits well with what we are discussing. We participated, my group participated to an American worldwide survey of dupilumab in pregnant women. And there is another paper that was published by other also, dupilumab in our series that was led by Jenny Muracy from USA, and another one that published by another group. Dupilumab was considered really as safe. So if you go into the FDA, you will not find this information, of course, so it will be on your own responsibility. But if you see that in pemphigoid cases, oral moderate 0.5 milligram kilogram prednisone is not giving quick or good result, I think that the step later on would be dupilumab. And dupilumab will be, in the current time, have to be considered. But just remember that you are not covered, let's say, by the SCP, the summary of the characteristic product, because it's still not allowed. But if you are in a hospital, in a university department, or in something, you can do what we call the equivalent of tumor board and have discussion with your staff people, and they stay and say that within the risk, with the benefits and the risk, dupilumab is considered as a potential one, as a potential safe biotherapies. Which topical treatment should be avoided during pregnancy? Of course, there is a lot of topical treatments that are considered to be contraindicated, mainly retinoids. Of course, also the ones that we give for actinic keratosis or even for mycosis fungoides. What is allowed as topical treatments is topical steroids, topical antibiotics like erythromycin. This one is allowed. And for benzoyl peroxide, there is still a discussion, but benzoyl peroxide still contraindicated by FDA. But there are papers showing that it's not so much contraindicated. So these are for topical ones. There is still a lot of questions, Youssef. I don't know if we will have the time, but there is an interesting one. I read it for you. Are there any identified genetic or HLA association that predispose women to gestational dermatoses? So the answer is yes. It's not for all gestational dermatoses. There is HLA association that predisposes for pemphigoid gestationis. So it's HLA DR3, DR4, and null allele for C3 or 434. So you have alleles that predispose women to pemphigoid gestationis? Are there long-term risks for mother who had pemphigoid gestationis? The only risk for mother who have pemphigoid is recurrence at induction of estroprogestative contraception. So we try to give them only progestative contraception, but not estroprogestative. And then we try to follow up later pregnancy, but there are no longer term. And then the last question, Youssef, it was a lot of interesting question. Should patient with autoimmune gestational dermatosis be screened for other autoimmune diseases later in life? No, because the risk is only for later pregnancies or later estroprogestative contraception, but not for later older autoimmune in life, Youssef. So if you have pemphigoid, you can screen for genetic association, yes, but usually we don't do it. You can try to avoid estrogen and just follow up better their later pregnancies. Treat them topically. If topical corticoids are not enough, you can go to oral corticoids. And oral corticoid should be enough. And if really, if you are in resistant oral corticoids, you can discuss case by case and with our colleagues and by seeing with the patient if dupilumab is needed, but this is really at your own responsibility because it's not yet allowed. This is what I can say at this time, Youssef. Interesting discussion, I had to say. I think I have no more question, Youssef. I'm looking. Tu m'entends, Youssef?
So I think we have two more questions, but because we are on time, maybe the last one: should patients with autoimmune gestational dermatosis be screened for other autoimmune diseases later in life?
No, I answer it. So the answer is no. You have only to follow up for contraception, no estrogen, but only progestative one. Follow up the later pregnancies, but you don't have to follow them on longer time, because the disorder is really linked to the fact that you have placenta triggering of autoimmunity, and then no more risks at later in life.
Thank you, Selin. Excellent presentation. And also, I would like to thank Dr. Rami Abadi for his dedication and continuous support. I also extend my thanks to all those who participated, shared comments, and asked questions. I wish you all a safe weekend and look forward to seeing you next week for our upcoming webinar, which will be focusing on mental health support for both physicians and patients during war times. Thank you, Salim, and have a good evening.
Prayers for Lebanon and all the region.
Thank you for your presence.
Thank you all, colleagues. Bye-bye.
Thank you all. Bye.